So my task in the next 20 minutes is try to overview with you the role of and let's say the manner to try to adapt nutrition during CRT. And it's far from being an easy task, because we know there is a lot of problems with nutrition during CRT. Underfeeding is one of those. And then we have no hard data on CRT and nutrition, no RCT. We have a lot of formulas, almost 200 types of different formula. I will speak about this. And then what about indirect calorimetry? Can we use this in CRT? What about the way of doing today more proteins in this group of patients? And how to increase feeding? Then the depletion syndrome, because we are losing many nutrients with CRT. And what to do with glutamine nowadays. And some recommendation for the bedside. Right, problem with nutrition in CRT. So we know that so far, although we invent indirect calorimetry in the 80s, nobody until now, and till many years to come, I suppose, can be able to do indirect calorimetry during CRT. There are lots of pitfalls. I will come back to this. As I told you, there are more than 200 formulas and almost 50 for nutrition during CRT. And I will show you what we find out about this. Then we need some time to mix TPN and enteral nutrition. There is a risk of overfeeding. It's very limited, but do we know what we are doing? That's another question. Then we know from AKI there is a risk of hypertriglyceridemia. We need to check this very often, at least twice a week. And we should go, regarding the latest study, up to 1 gram of nitrogen per kilo per day. Now, nevertheless, although we don't know a lot about the quantity and the quality of nutrition we need to give to this patient, we need to do our best, because we know that an adequate nutrition will increase recovery, normal functioning. It's important for immune functioning as well. We want to avoid over and under feeding, but can we measure it? We know that underfeeding is very bad because it increases morbidity, mortality, that's less clear. It's increasing infection, decreasing wound healing, and increasing length of ventilation. Not too good. Right. So, as I said, also a huge problem of evidence-based data. No RCT in nutrition during CRT. So we are really stuck with observational study, and that's not too good. So we cannot show any effect on hard outcome in this subgroup of patients. So we are left with recommendation, expert opinion, observational study, not too good really. And we know also it's quite difficult to measure the loss of the nutrients during CRT. Okay, so let's look to this predictive equation to try to know what we need to give as quantity and quality of nutrition for this patient. And we did a study with our group a few years ago. We published this in Minerva Anesthesiologica in 2013. And you see, we went to look at 200 formula that been used worldwide to know what are the need of nutrition for, let's say, ICU patient, and 50 of them were deemed to look at nutrition in patient in ICU plus CRT. And let's say in the normal ICU population, look, you have a difference between plus 500 kilocalorie up to minus 500 kilocalorie. So 1,000 kilocalorie difference between one formula to another one. And then when you look more specifically to nutrition during CRT and those formula, then you go from plus 500 to minus 1,500, 2,000 kilocalorie difference. What can you do with those formula? Nothing. Just push everything in the bin. That's all. For this population, really, even the other population, we should forget about. But the advantage for the other population, we have indirect calorimetry that is working nowadays with the third generation. What about indirect calorimetry in the CRT patient? So we know it's a beautiful way to measure the need of the patient, because if the cell is needing nutrients, then the cell will use oxygen and will produce CO2. Marvelous concept. Indirect calorimetry. Good. Very good. But what is the problem with CRT? Well, the problem is not only the oxygen removal, but mostly the CO2 losses during CRT. And we did a pilot study that we are just submitting to GSN a few weeks ago upon 20 patients, and we measure at 5 different places CO2 into the circuit. And first, we find out that 10% of the CO2 of the patient is floating through the circuit. Then 10% is something. And we thought, well, probably it's something to do with the bubble trap. We see so many bubbles going to the bubble trap. No, only 10% of the losses. 90% of the losses are going through the filter. So that's really very interesting, because it's the first time that we are able to really measure effectively CO2. The next step would obviously to be able to also measure the loss of oxygen, and then to try to build a strategy to measure indirect calorimetry in CRT patient. But there is still something to do. Anyway, this is perhaps the first step that we can achieve. Now, we saw that measuring energy, calorie during CRT for nutrition is very difficult. So we cannot rely on formula, we cannot rely on indirect calorimetry so far, and we are just stuck with some recommendations. Now, what to do with proteins? So we know, indeed, it's important for the synthesis, and we should provide more amino acids because there are many loss of amino acids. And this is one of the very few randomized controlled trials on the topic from an Australian group looking at 50 patients in multiple organ dysfunction syndrome with mechanical ventilation and CRT. And they had a strategy to have, in a randomized fashion, to increase the protein up to 2.5 grams per kilo per day. A lot. And they were able to show that they had a better nitrogen balance, make a lot of sense, but also, although with a small number of patients, a better outcome. But nobody has been able so far to reproduce this study in this specific group of patients with CRT and upon nutrition. Now, how should we increase feeding calories, which is still the main goal, far before protein? So normally, if we have isocaloric feeding, enteral feeding, what we shall do after a septic shock, we just accelerate deresuscitation using a continuous technique like CVVH to make room for extracting more water. That's going to allow the patient to have less overfilling, and then maybe to be wean off the mechanical ventilation, but also to have enough enteral feeding. We know nowadays we have hypercalorics, 2 kilocalories per milliliter of enteral nutrition, and so maybe by doing this we can avoid to deresuscitate too much with CVVH. But we know with this enriched calorie nutrition, we get a lot of diarrhea, and it's not so efficient as we thought. Now, we know we are losing a lot by doing CRT, not only bad things, but also very good things. And this is the list. So we know micronutrients, so trace element, hydrosoluble vitamins, amino acids, energy, and micronutrients. Drugs and albumin is another story. Now, still in the year 2000, the group of Santoro and other groups, when they asked students to be on a hemofilter and to see what was the loss of calorie in one day, they were close to 1,000 kilocalorie per day. It's a lot. But just making parallel, the CRT device versus the ECMO device. CRT device is, it's not very well rewarm. We have a rewarm system only on the tubing, whereas we have no rewarming system on the filter, where 90% of the loss are coming from the calories in terms of warmth. And also, when we compare to ECMO, we have a rewarming of the oxygenator. So this is making a huge difference. I think we should really have a plan for the future for this, because this is still a major problem. Because if you want to say, I want to give back the 1,000 kilocalorie, I'm not sure they lost that. And if you are giving it, you are really close to 3,000 kilocalories. So you may then be overfeeding the patient, which is not good. So we need really to make progress on this as well. Now, regarding micronutrients, so we know we lose amino acids. I will come back to the story of glutamine. We lose soluble vitamins and trace elements. Okay. Very logical for soluble vitamins, because it's the less bound to the protein, and the same goes for minerals. Glutamine. So we said for many times, almost 2 decades, we should supplement glutamine in CRT patients. And then came this famous study from Darren Ayland from Canada. And look here, when the number of organ failure is more than 2, what a very bad outcome for the patient. We're almost killing the patient when we are giving glutamine to this patient. So far, I would really recommend to stop giving glutamine in patients with CRT, because there were some patients with CRT and AKI in this study. Right, so what is left? Very good question. So I will try to do some recommendation, but very prudently, obviously. This is a recommendation table that we published in Blood Purification in 2013. So energy, I told you, we cannot rely on formula. We cannot rely on indirect calorimetry so far. Indirect calorimetry can now be used in ECMO patients. We've been able to have a proof of concept that we published 2 years ago in Acta Anesthesiologica Scandinavia. So this is possible now for ECMO. Our group has been doing this, but CRT not yet. So we need to rely on recommendation between 25, 35 kilocalories per kilo per day. Okay. Protein, 1.5, 1.8 gram per body weight per day. Then glucose, we know with AKI we have a lot of hyperglycemia, but do never forget, whenever you stop enteral nutrition, your patient will have hypoglycemia. So we need still to have a closer eye on glycemic control. Lipids, we know there is a problem with the metabolism of triglyceride, and we need to check this at least twice a week. We need to supplement vitamin, water-soluble vitamin. I put here the list. Only a few fat-soluble, and then some trace element. Vitamin, water-soluble, I will say a last word about this. Now, this is the recommendation, not based on the randomized control trial, obviously, mostly based on observational study. And now, for the future, hopefully we can have an enteral nutrition, not with glutamine anymore, but with all these other elements that I was speaking to you. It's not there yet. Conclusion, we have problem with nutrition in CRT. There are no RCT in CRT upon nutrition so far. Formula are useless. Indirect calorimetry is still not validated. What to do with proteins? Very good question. Try to reduce the depletion syndrome and compensate for the losses. And forget about glutamine, really. And recommendation at the bedside that I show you. Lastly, I will finish off with a case. Because people say, well, supplementing, something during CRT, I don't care. Well, we had this lady, 30 years old. 4 years ago, she had a gastric bypass for obesity. And she was hospitalized in another institution for septic shock and AKI. And she was doing well. She received 10 days of CVVH. And then almost suddenly, she went into deep coma. Then she was transferred to our university hospital. And we were very, very upset about this because we didn't find any cause. And we just do everything, CT scan, MRI, LP, looking for viruses, everything. Everything was negative, and the patient was sitting in coma. And we said, gosh, what are we going to do here? And then at some point, we said, well, let's check perhaps everything in terms of metabolic pathway. And at some point, we were checking vitamin B1, thiamine. And because we know that patient with gastric bypass has a very low thiamine, and we get the first result, 0. We say, it's impossible. Second one, 0. Third one, 0. And because in the first hospital, they just give CVVH without supplementing thiamine. And this patient had a beriberi, and we know if we are not giving timely enough thiamine back, the patient will have irreversible damage in the brain. So we should not forget about supplementation during CRRT. Thank you so much for your kind attention.